child, you will be much better off. So this is a study in India, from Chandigarh, and here again you find the respiratory events constitute about 56% of all cardiac arrests. Now looking, this talk we'll discuss along the following lines, some very few differences because much of it you must have studied in your post-graduation and all that. What is how in airway management, how children are different from adults, what sort of evaluation you will do and how will you prepare if you are forewarned or if you anticipate a difficult airway and you have everything ready, you'll be much more equipped and you'll be better, you'll do a better job. So what can you do in terms of evaluation? And we are doing a few case scenarios just to highlight some of the aspects of airway management in children. So some of the differences here, you can see that the neck hardly exists, the occiput is large, and as against this older child where you need to keep a pillow to get the line of sight, like Dr. Apex was explaining, all the three axes in line, even for ventilation, even if not for intubation. So just extension at the atlanto-occipital joint and a good mask fit. Mask fit and a good mask ventilation is very, very important, especially in children. Most of the time, junior anesthetists, or if you are not very experienced, if you do your mask ventilation badly, you can get into trouble. Now, among the physiological differences, an increase in respiratory rate, decreased chest wall compliance, elastic recoil. We were talking yesterday, Dr. Apex was explaining how you fill the FRC with 100% oxygen and that gives you enough time before desaturation. In the child, the FRC is low and the oxygen consumption is high, so straight away you're at a disadvantage and the time for desaturation significantly is less. So in a child, this is the x-axis shows the time in minutes, the y-axis the arterial oxygen saturation. This is a 1 month old, the saturation is at about 90 at less than 2 minutes. In fact, in a newborn without pre-oxygenation, it's only 15 to 20 seconds before desaturation. So this is something that you have to keep in mind. They don't give you much time to react. What's good about the difficult airway between children and adults? The incidence of difficulty is less in children. In older children, it's about 0.07 to 7%. Truly difficult laryngoscopy is rare as well. This means that we have less experience and we are less likely to handle the situation unless we do something like a workshop specially for it. Now, what's bad is there are not so many predictive tests. In adults, you have Malambati, you have so many radiological tests, you have so many distances that you can measure. In children, nothing is foolproof. Each child is of a different size. You can't even say so many finger breadth mouth opening. Even that is not something that you can measure. And most of the time it's the experienced eye or the gut feeling that you feel maybe this is not okay, this is not right. But again, we'll try to look at some of the indicators that will help you to judge if this can be a difficult airway. All airway management tools are not available in small sizes, especially most of the studies are in adults, everything is extrapolated to children. You see that you have a fiber optic bronchoscope, the larger size is available. In a large institute, you may not even have a smaller size. And especially if it's a newborn, we are a pediatric institute and we are really at a crux at times when you have a really small baby and you're worried, there's going to be an airway problem because there's really no tool that can help you. Now, what's worse is children are not cooperative, so you need to anesthetize the child before you can do even a evaluation or a fiber optic bronchoscopy. Fiber optic bronchoscopy awake, this is from Goraj with Dr. Apex where they do all the blocks, the patient is awake, you do a spray and then you can introduce the tube and the fiber optic scope and the endotracheal tube. But the child, this